Friends, welcome to my workplace at Ranaghat, West Bengal, India. Chopping a free-floating hard nucleus is challenging even for the experienced phacosurgeons. This is a hypermature morgagnian cataract. In this case, we will see how to chop a free-floating hard nucleus. Free-floating means the nucleus is free. After removal of the milky fluid, the nucleus moves freely in the bag, and this kind of nucleus is not easy to hold and not easy to chop if the nucleus is hard. And in most of the cases, since this is a hypermature cataract, the nucleus is hard. In some cases, the nucleus becomes small in size because of melting of the epinucleus and cortex into milky fluid, but the nucleus remains, though it is small in size, it is hard. So, we have going to after staining the capsule, we are going to make a puncture. A puncture has been made with a cystitome, and we can see the milky fluid has come out. A 23G Simcoe is used to remove this milky fluid so that visibility becomes good. And now again this is Hylucoat, a combination of chondroitin sulfate and sodium hyaluronate, and then beneath this is SPMC, a modified soft shell technique. And now Capsulorhexis is being done with the Utrata forceps. Fortunately, in this case, the capsule, the zonule is not weak, but fortunately, we should not use this odd in surgery. Even if it is weak, we have to manage it in the proper way using capsular tension ring, whatever is required. In this case, zonule is not weak and the pupil is adequately dilated. And now this is the free floating nucleus. See how the phaconeedle goes, the bevel down. If you make the bevel up, it is difficult to hold. It will not bury into the substance. But if you make the bevel sideways or bevel down, then immediately it engages in the nucleus and you can hold it nicely. The leathery nucleus is a stubborn nucleus and it is resisting crack, but see the technique. What I am doing now is I am holding the nucleus nicely and the chopper goes behind the nucleus, and between these two instruments the nucleus is crushed and a nice through and through crack is obtained, and then we get free nuclear pieces. Hold it nicely, go behind the nucleus, between these two instruments, crush the nucleus, keeping hold, nice hold, and then you get good cracks. And this is the endonucleus. Endonucleus along with the fragment is emulsified. Ultrasonic energy used in this case is 80%. Flow rate is 48 ml per minute and vacuum is 480 millimeter of mercury. We can use less vacuum and flow rate, there is no problem. The vacuum can be anywhere between 400 to 500 and flow rate can be 40 to 50. It is up to the surgeon. Just find out your comfortable setting and do the surgery. These last pieces are being emulsified under stereocoaxial illumination. When we use stereocoaxial illumination, depth perception increases. And now to emulsify the last nuclear pieces, am taking help of viscoelastic substance because the posterior capsule does not have any cushion, no epinucleus, no cortex covering the posterior capsule. So, we have to be careful. Some viscoelastic substance filling up the capsular bag, and then the pieces are again emulsified. And what is the safest technique in such cases for emulsification of the last piece? Yes, the IOL scaffold technique. If you just make a small touch to the posterior capsule, and if there is a small rent and if it becomes bigger in course of time, all your efforts are gone. So, the safest way in hypermature morgagnian cataract to remove the last nuclear piece is to use the IOL scaffold technique, where you fill up the capsular bag with viscoelastic substance and place the intraocular lens first in the capsular bag. The main wound is enlarged if it is required. I am using a B cartridge, so I enlarge the main wound little bit, and now the intraocular lens goes in the capsular bag and the nuclear piece is placed over the intraocular lens, and now it is safe to emulsify this piece of nucleus. So, remember, if it is a hypermature morgagnian cataract where the posterior capsule is bare, means there without any cushion of covering of cortex or epinucleus, this is the safest technique. Place the IOL, support the posterior capsule and emulsify the last nuclear piece. Many a time the zonule is weak in hypermature morgagnian cataract. In those cases, at the very beginning, just after capsulorhexis, we should place a capsular tension ring. Without the placement of capsular tension ring, we should not proceed if the zonule is weak. And now see how I am removing the visco from the capsular bag. The irrigating probe went behind the lens in the capsular bag. The bag is nicely irrigated. Aspiration is in the anterior chamber in front of the intraocular lens, and all the viscoelastic substance from the capsular bag is nicely removed. And now the side port is being closed by corneal stromal hydration. A nice lavage of the anterior capsule is done. Any viscoelastic substance that sticks to the posterior on the back of the cornea, that is any viscoelastic substance sticking to the corneal endothelium, is gently removed. The antechamber is nicely formed and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, compassion and great surgical competence.